Good afternoon. My name is Kimberly Abrams, and I'm here to share my research on medication assisted treatment, or MAT, in residential treatment programs for opioid use disorder. This is part of my DNP 816 coursework at Northern Kentucky University. First, I'd like to say, as a clinical nurse manager in an inpatient residential treatment center for substance use disorder, and with over 28 years of experience as a nurse, I've seen firsthand the challenges patients face in achieving long-term recovery from opioid use disorder. And it is my work at such a residential treatment facility that has motivated me to explore evidence-based interventions like MAT that can improve treatment outcomes and support sustained recovery. My PICO question focuses on patients with opioid use disorder, or OUD, and whether implementing medication-assisted treatment, or MAT, alongside standard care can improve the completion rates of a 45-day residential treatment program compared to standard care alone. This question is critical because opioid use disorder is a public health crisis affecting millions in the U.S., with high dropout rates in treatment programs. MAT has been shown to address these issues by increasing retention and reducing relapse rates, making it an important area of exploration. Medication-assisted treatment has demonstrated significant benefits for patients in residential settings. Despite being offered by fewer than half of these centers, it has consistently improved patient retention and engagement in treatment. By addressing critical psychosocial barriers, MAT supports patients in staying on track and completing their recovery journey. Early studies on integrating MAT into existing therapeutic programs show promising outcomes, including reduced relapse risk and better long-term results. These findings emphasize MAT's essential role in enhancing the effectiveness of residential treatment programs. While the data highlights the benefits of MAT, there are still considerable gaps that need to be addressed. For one, we have limited understanding of the long-term outcomes of MAT in residential settings. Additionally, there is insufficient research on how patients perceive and experience these treatments, and the lack of standardized protocols for integration remains a challenge. Minimal exploration has been done on MAT and how it affects group therapy dynamics, and we still lack robust data to quantify the specific retention benefits of MAT. Addressing these gaps is critical in optimizing its implementation and impact. To address these gaps, a few key steps are needed. First, we must expand research, particularly longitudinal studies, to assess MAT's long-term effects and gather patient-reported outcomes. Policy advocacy is also crucial to support MAT integration and ensure equitable access. Training programs for staff are essential to provide the skills and knowledge needed for effective implementation. And finally, we need to secure funding and allocate resources to make MAT accessible to more patients, especially in underserved areas. Taking these steps will strengthen MAT's role in residential care and improve outcomes for patients with opioid use disorder. I thank you for your time and look forward to your comments.